So this is a sheaf of columns that are written by André Picard. I clipped them and kept them because they're so lucid, because he's one of those rare enough columnists who, in covering a beat that's complex and full of conflicting data, just kind of gets it down to clear and simple stuff, and you begin to think, well, why don't we just hand the whole health system to Andre and have him kind of clear it up? We all know the struggle to control costs. We all know the kind of finger pointing that's happening towards older Canadians. We all know about the tension between private and public. There are pharmacologies, there are drugs. It's all quite confusing. Andre.
Thank you. So I'm going to talk about healthcare this morning, and the blues are a good segue into the topic. That's because Canadians are conflicted. We love Medicare with all our hearts. It's a source of great national pride. Universal healthcare embodies our values and gives us our heroes. Just as importantly, Medicare is what distinguishes us from Americans, from the United States, especially now that Canadians never win the Stanley Cup. But we're frustrated by the long waits, the rickety infrastructure, the growing inequity in access to care, especially for those who need it most, the frail elderly and people with chronic illnesses. We all know that something's wrong with the system, but we're not sure what exactly. We don't know how to fix it, so we endure it. By the way, while my focus this morning is going to be on Canada, everything I say applies to the US. I know there's some Americans here. It applies to the US times 10, because they have 10 times as many problems as us. Now, I've been writing about healthcare for 25 years now. Just had my 25th anniversary at the Globe. Like you, I've heard all the bitching and the moaning and all the political bullshit for a long time, and I'm tired of it. Like David Chilton, I want us to stop talking about all the negative stuff. So what I want to do this morning is offer up something a bit different, some constructive criticism and some practical solutions. And the 15 minutes I have left should be plenty to solve all our woes. Now, because this is an audience of intellectuals, I've sought guidance from a great philosopher. Lawrence Peter Berra, or Yogi, was a Hall of Fame baseball player and a manager with the New York Mets. He was not a cartoon character. That was Yogi Bear, just for those of you who aren't baseball fans. Now, there's no formal relation between the two. The nickname that Yogi got came from his habit of sitting cross-legged, like a guru. And I'm going to use him like a guru today. Yogi the man is best known for his malapropisms, for mangling the language. But in my mind, he doesn't get near enough credit for his profundity, or for being smarter than the average bear. So let's see what Yogi can teach us about Medicare and how to fix it. Now, I've observed a lot of changes in my time as a health reporter, and I can tell you one thing, that in the past 25 years, care has improved a lot. We seem to forget that. Care is great. We have better technology, better surgical techniques, better doctors, better nurses, better everything. We do the plumbing really well. And medicine is that. It's plumbing with more expensive tools and slightly better paid plumbers, but only slightly. The care is exceptionally good once you get in the system. But access to care and equity of care provision are far worse than they used to be. That's the rub. That's the problem, not the delivery. We deliver great care not because of the system, but in spite of the system. Our health system and health insurance system were designed in the 1950s. The principles of Medicare were not carved in stone by the hand of God and retrieved from a burning bush by Tommy Douglas. That is the Canadian mythology, but it's not true. The system was designed by mere mortals for the needs of a post-war society. And let me tell you about Canada when Medicare was born. It was a young country, average age 27. And healthcare consisted of acute care: childbirth, traumatic injury, minor surgery. If you had cancer or heart disease, you essentially went to hospital to die. Today, Canada is an old country. Our average age is 47. We still need acute care, of course, but about 80% of all our health care consists of treating chronic illnesses, like COPD and heart failure. 5-year survival rates for cancer are now in excess of 80% for almost all cancers. So cancer's become a chronic illness as well. But our health system is still designed to deliver episodic care, acute episodic care. And our insurance system is designed to remunerate piecework. More than 70% of physicians are still paid fee-for-service. So our fundamental problem is that we're trying to deliver 21st century care with a 1950s system. Imagine if we were trying to do that in any other industry. But back to Yogi. We have a love-hate relationship with Medicare. Some love it unreservedly, others hate it passionately. The most popular line of attack goes something like this: Medicare is a socialist system, and it needs a good dose of private sector discipline. It's often stated as fact that there are only 3 countries in the world that ban private health care: North Korea, Cuba, and Canada. Quite a rogues gallery. This, of course, is utter nonsense. There's nothing dictatorial or socialist about Canadian Medicare. It's a publicly funded insurance system designed to spread risk over an entire population. There is, yes, a prohibition on the sale of private insurance in 5 provinces, but only on medically necessary care, meaning hospital and physician services. Yet, we spend $60 billion a year on health services privately. That compares to $130 billion in public insurance spending, which is our taxes. It's not free. Now, there's no prohibition in Canada on the private provision of care. In fact, the vast majority of our care is privately delivered. Physicians in this country are independent contractors. Hospitals are not-for-profits. And pharmacies, labs, home care, nursing homes, for the most part, are private for-profit businesses. And 22 million Canadians actually have private health insurance for things like prescription drugs, ambulances, mobility devices, etc. So the problem is not that we have a public insurance or private insurance system. We have a mix, but we don't have the mix right. That's the issue. We have this bifurcated system that pays for 100% of doctors and hospitals, but less than half of drug costs, and less than half of home care costs, and 0 dental costs. We're the only country in the world that has a system like this. The most efficient health systems in the world, those of Europe, have an 80-20 public-private split of insurance, something Moses Znaimer will no doubt appreciate. The 80-20 is back. In the past 25 years that I've been working, health spending has risen from $40 billion to $200 billion. When things go wrong, for example, when health spending is out of control like this, we look for scapegoats. In Canada, we like to blame all our healthcare woes on seniors, on the Grey Tsunami. Now, the notion that baby boomers are bankrupting Medicare is a big fat lie. It's simply not true in any way. There are 2 things that are driving rising health costs. One is the increased use of healthcare by all age groups: more pills, more technology, more doctor visits, more hospital time. And number 2, labor costs. 70% of all healthcare spending goes to paying workers, and we have the best paid workers in the world. Now, each Canadian consumes in their lifetime about $500,000 worth of care, if you calculate it. More than half of our spending occurs in the last 3 months of life. People seem to be shocked by this, but this is perfectly normal. You need care when you're sick and you're dying. There's nothing unusual about that. And that's exactly why we have insurance, to pay it forward. We pay our whole lifetimes so we can cash it in at the end. The other reason we have insurance is to spread risk. In any given year, 1% of Canadians account for 25% of health spending. 5% account for fully half of all health spending, $100 billion a year. Health, like wealth, is not evenly distributed across society. That's why we have to spread risk. Now, the other reason spending is skewed in this manner is that we grossly overconsume medical services in our final weeks of life. We should be spending on pain relief and palliative care, not on so-called heroic interventions that prolong suffering. Someone with terminal cancer who's 95 does not need a hip replacement. They need compassion and palliative care. We have to stop viewing death as a failure and focus instead on a good life with a good death. So the next big debate in Canadian society has to be about dying with dignity. Now, does anyone here know the mission statement of Medicare? Now, there are no hands up because there is none. We have a $200 billion a year enterprise with no stated goals and no clear purpose. That's a bit shocking. We talk endlessly about sustainability, but we have no idea what we want to sustain, aside from doctors want to sustain their jobs. Now, if Medicare is adrift, and I think it is, it's in large part because it's devoid of vision. Here's what I think the stated purpose of Medicare should be: promote good health, alleviate pain and suffering, restore health and extend life when possible, and ensure a good death for all Canadians. I think we can afford to do that with $200 billion. But do you know what the overriding goal of the health system in this province is, in Ontario? It's to limit spending increases to 2.1% this year. Is it any wonder our health system is sputtering if we have goals that are established by accountants and not by people? And I'm an accountant. Well, it took a while, right? So I'm an accountant by training, so I can say that. So let's stop focusing on money and start focusing on people. Now, the defining characteristic of the Canadian healthcare system is waits, the queues. We've been led to believe that this is because we have shortages of workers. Again, that's not true. The problem is twofold. Number one, health professionals are not working to their full scope of practice. We have a lot of physicians and nurses pushing paper instead of doing hands-on care. We need to have doctors doctoring, nurses nursing, and pharmacists farming, with a PH, of course. And we need them working in teams, not in isolation and at cross purposes. The second problem is one I mentioned earlier. We're trying to deliver chronic care with an acute care model. A square peg in a round hole doesn't work. We need to turn the health system on its head, to place the emphasis on primary care, not tertiary care. In other words, a lot less hospital care and a lot more community care. We need to care for people where they live, in their homes, in their communities, not in soulless, germ-infested institutions. This isn't a medical problem, it's an engineering and an administrative problem. Medical errors in Canada kill 24,000 people a year. 1 in every 10 prescriptions is wrong. 1 in every 9 hospital patients is harmed. Treatment mistakes are one of the leading causes of death in this country. Only cancer and heart disease kill more people. This isn't to suggest that all errors are preventable. They're not. But we need to make delivering quality care our principal goal, our driving ambition, with innovations like checklists. In Canada, we're too obsessed with quantity and too indifferent to quality. The other issue here is that we don't make enough right mistakes, as Yogi Bear would probably tell us. Earlier this week, we heard about the need to embrace failure. In this context, that doesn't mean accepting deadly errors. We should never accept that. But it means embracing innovation, making mistakes to do better eventually. In Canada's health system, we're set in our ways and too accepting of mediocrity. I think that attitude is best summarized in an anecdote from the great philosopher himself. So Yogi was driving to a baseball game with his teammate Phil Rizzuto one day, and this conversation ensued. Phil, hey Yogi, I think we're lost. Yogi, yeah, but we're making great time. In Canada, Medicare is making great time, but it's going nowhere fast. Now, like Yogi Bear, we often cast our gaze in the wrong place, and we miss the obvious. Now, the biggest mistake we make in Canada is to compare ourselves to the US system constantly, to mollify ourselves with the knowledge that we have a universal system and they don't. But the 25 richest countries in the world all have universal health care, with only one exception. What we fail to see by fixating on Uncle Sam's bare-assed failure is that the other 23 countries do health care cheaper, faster, and better than we do. The people who say we can't touch Medicare because the alternative is US-style health care are creating a false dichotomy. We should be casting our gaze to Europe, where universality is the norm, but health systems are not like Canada's. The mathematics of healthcare are a lot like the mathematics of baseball. Now, by that I mean that good health has very little to do with medicine, yet that's where we spend all our money. It's estimated that about 15% of our health status is attributable to medicine, to medical care. Another 15% attributable to genetics. The balance, the vast majority, depends on socioeconomic status. The best way to ensure you will have a long, healthy life is to pick your parents well. Now, we can't all do that, so we have to level the playing field. And the way to do that is to redistribute wealth. And that's what Medicare does. The mistake we make is thinking that offering health insurance is sufficient, and it's not. If we want a healthier population, we need to invest in education, social housing, job creation, and other elements of a social safety net. The countries that have the healthiest populations are not those who spend the most on health. They're the ones with the fewest inequities. Inequity is our greatest killer, and money is the best medicine we have, and we don't prescribe it very well. You know what Canadians do better than anyone else in the world? We study healthcare. We've mastered the inquiry in lieu of action. Vast forests have been felled to produce reports. More than the beetle has killed, health reports have killed. There's approximately one major healthcare study for every year that Medicare has existed. But I'm going to let you in on a secret. Every one of them says exactly the same thing. Every report from the Hall Commission in 1961 through to the Romano Report in 2002 through to the latest Senate report in 2012 make the same major recommendations. So I'm going to summarize 50 years of collective wisdom for you in 5 short sentences. 1, access to prescription drugs is profoundly inequitable, and it offends the principles of Medicare. We need some form of pharmacare. 2, treating people at home is safer, cheaper, and more humane. We need home care. 3, 80% of Canadians over 65 have at least one chronic condition. Primary care needs to be bolstered. They don't need to be in institutions. 4, prevention is cheaper than treatment. Invest more in education and less in sickness care. 5, there's no excuse for the waits we have. But if we implement the other fixes, there won't be waits. Now, if we continue saying that Medicare is unsustainable, it will become a self-fulfilling prophecy. But we need healthcare, but the need for healthcare is never going to go away. What's unsustainable is the status quo, an out-of-date structure for delivering and paying care. The values we have as Canadians, the values that Medicare should embody, like fairness, equity, and compassion, are as relevant as they've ever been. We need to give them life. Yogi Bear understood that you have to play the entire game to know the final outcome. We can't just give up because the going's getting tough. Now, there's pretty broad agreement out there on what needs to be done. I just gave you the top 5. What we need is leadership. So where's it going to come from? I think it's going to come from the provinces, from a new generation of leaders like Brad Wall of Saskatchewan. But above all, it has to come from you. It has to come from the public. You have to create a demand and create an environment for frank discussion, or an adult conversation, as some like to call it. The leaders in business, labor, healthcare, all have to put a little water in their wine, and finally make patience the priority. The final point I want to make is that I'm actually quite positive about the future. Every change that needs to be made can be implemented in about 12 to 18 months, if we set our minds to it. We're ready for this. We're at a tipping point. What we need to do now is less talking and more doing. Thank you very much.